which we do at the Leicester. It is for the veno-arterial ECMO, which is dial-up without introducing the bridge. This is how we invented the procedure, and it is called as the reverse flow dial-up. It is based as a chapter in the latest of ELSO rate. The system bridge for veno-arterial ECMO is if you think you are ready to come out or if there is any aid the tubing. These are the only two circumstances we consider introduction of a bridge. Otherwise, we don't go for bridge in veno-arterial ECMO. So, reverse flow dial-up is you reduce, you start from zero, like on the patient, you ventilate the patient, minimal inotropic support, and then reduce the flow to zero. The pressure transducer, which is detecting blood from the circuit to the patient so far, will be reversed. Now it will start detecting the flow from the patient to the circuit, and it slowly increase the flow. Generally, when you reach around 100 ml or 150 ml in a neonate and in a child, that should be enough. You detect the flow at that stage. So now it is reverse flow from the patient to the circuit than the patient to the circuit, rather than the circuit to the patient. So that is the reason it is called as reverse flow dial-up. Majority of the patients do tolerate this, but there are some patients who don't tolerate it. If the myocardium is very weak, then those patients may not be able to tolerate it. But in general, it is advisable to try this reverse flow dial-up. Further details you can read from the ELSO Red Book. It is a simple procedure, exactly the same thing, like taking the sweep gas off when you are coming off, continuing with the reverse flow. Apart from that, you don't do anything different. No need for heparinizing both the circuits. It's simply one circuit only. Still the blood flow is going on. No need to change medications. Everything is the same, like a venous dial-up. The only difference is instead of forward flow and introduction of a bridge in that, you tend to do a reverse flow, but here you tend to reverse the direction of the blood flow by changing the direction of the sensor. That's the only difference in that. Try if it helps. If it doesn't help, you can go for arterial switch, which will be with us in January. You can explain better on that. So, neuro monitoring is one of the very important factors because there were questions coming up yesterday and today as well. How do you do neuro monitoring? As brain is the most important structure, it's a key factor for accepting a patient for ECMO as well, and it decides the course of ECMO altogether. So it depends on the age group. If it is if it is a child, neuro ultrasound scans might help. But other than that, if it is a adult, adolescent or a child, probably pre-ECMO neurology, pupillary signs, CT scan of the brain might be helpful. Ideally, if we can have a pre-ECMO CT scan of the brain, that would be helpful, especially when the neurology is in doubt. There is no point in putting a brain dead patient on ECMO. That is the entire basis for this. So you have to be sure about neurological integrity of the patient before you accept a patient for going on to ECMO. So that is very important. From the ELSO registry point of view, neurological complications are there. Nearly 5% of the cases we tend to see as a bleed, CNS bleed in them. This is the international summary. You can see nearly the various percentages. 1% of brain death incidents to 3.5% in adults is the incidence of brain death, and the other most important is CNS infarction 7% in neonates to 2.1% in adults. CNS bleed is 7% in neonates and 4% in adults. So those numbers are important. This is again another synopsis about the major insults to the brain while they are in ECMO. The risk factors are ischemia, as you are talking about, to some extent systemic hepatization, alteration of blood flow dynamics, altered cerebral autoregulation and veno-arterial ECMO. We didn't have much of evidence in favor of that, but now with the help of cerebral oximetry, we are able to investigate further on it. The microemboli, which might pass from systemic circulation to the cerebral circulation, and the effect of carotid ligation and reconstruction. These are the major factors which will contribute to the risk with the brain. So it can manifest as bleeding, ischemia, and activity into varying numbers of patients. As per the studies, it could be different also. But I showed you the aggregate picture on the ELSO registry chart. Pre-ECMO hypoxia and hypotension, developmental problems may manifest by up to 2 years or beyond. So neurological follow-up is very, very important in these patients. Though they are apparently normal, but subtle changes such as learning difficulties may appear by school age, so they need a follow-up after ECMO. Intact neurobehavior in the form of history, alertness of the patient, size and reaction of the pupils, and some drugs which can cause significant dilatation of the pupils, cranial ultrasound scans and CT scans, they will be helpful for us in evaluating the neurological status. Ultrasonography is a reasonably good tool for identifying major intracerebral bleeds. So what we are looking at here, while on ECMO in neonates, is mainly is there a major bleed or not. You're not looking for minor insults as such, so you're really looking for major insults. Usually grade 1 bleeding is acceptable, grade 2 is also acceptable, but when it becomes grade 3, then it becomes unacceptable. So if a patient has a grade 2 intraventricular bleed, then probably as coming off ECMO is life-threatening to the patient, you can still continue to do ECMO by taking the patient on off heparin or on minimal heparin during that period. CT scans on ECMO need transporting the patient from ICU to radiology department. In some places, mobile CT scans are available, but in general, we all tend to transport our patients to radiology department for getting a CT scan of the brain. Preparation and personnel both are required because you have to be extremely careful cannulae are not slipping during this procedure. Dilatation of the ventricles and also increased haziness in thalamic region is seen in this. Cooling on ECMO before, from the NEST trial and other trials, hypoxaemia on neonates was stated to be cerebral protective. If there is a window within 6 hours post insult, if the patient goes on to ECMO, then you can start cooling the patient. But if you miss this window of 6 hours, cooling is not going to be effective. The general principle is following cerebral hypoxia or cardiac arrest, probably in those cases, just maintain the temperature as normal. No, don't reduce the temperature in any other groups, and fever is also detrimental. So just normothermia is the way to go ahead. Near-infrared spectroscopy, I've shown a bit of it to you yesterday, and we looked at these pictures as well. This is a very important way of knowing oxygen saturations of the brain underneath the scanner. It doesn't depend on the pulse pressure. It is also able to read at extremely low values and not cut out at value of less than 35%. There is growing data and growing usefulness. Some of the autopsy pictures how the brain hemorrhage can look like: intraventricular hemorrhage in a neonate, periventricular leukomalacia, okay, intraventricular hemorrhage in a neonate in an autopsy specimen. So, usefulness of near-infrared spectroscopy or cerebral oximetry that has been proven in all the age groups. Cerebral events could be detected efficiently. In this study shows a summary of systemic and cerebral events in 20 patients, bilateral drop in cerebral tracings. There was a systemic event at that time, or resolved with interventions, confirmed a neurological injury, etc. in those cases. But it is a useful tool to diagnose that. In pediatric patients also, long-term outcome of children treated with neonatal ECMO, increasing problems with increasing age. They have been reported as well from Netherlands and other areas. So these patients have to be watched further for the neuro-behaviour, school performance, and neuropsychological tests also. The follow-up is by means of ultrasound scans as well as CT or MRI scans for better delineation of the problems. CT is useful for identifying infarcts, diffuse edema, and atrophy. MRI and SPECT scans will be useful as well after ECMO. Possible adverse events of the ligation of carotid artery. There is no increased evidence of left-sided neurological damage in those with right-sided carotid artery ligation. Usually the other side vertebral artery will take over the circulation and will be able to look after. In minority of the cases, there may be effects. Reconstruction, majority of the arteries will remain patent at 4 years of age, although some may have mild or moderate stenosis. When the artery is repaired, one has to be very careful about aneurysm formation at the local site. So, early and late neuro monitoring in ECMO patients. Early monitoring during ECMO or just after, and the late monitoring is after discharge. We involve the pharmacology. This is the study I have been mentioning to. Dr. Lakshmi Raman is doing at Dallas about knowing cerebral cerebral have developed this by monitoring finding continuous and then feed to a computer transformance. It is which this intracerebral bleed is getting worse while on and monitoring, neuro monitoring after discharge is very, very essential. Any questions on this? Independent of hospital on-call staff. The staff in the transport team are trained to provide transport by road and also by air, utilizing a number of different vehicles. Almost all the times it is a consultant-led transfer there. So which mode of transport is depend on the distance, weather pattern, and the patient's condition. Glenfield Hospital is after the and getting ready for air transport. Royal Air Force planes used to help, helicopters used to help us before. We do have similar ones in India now, based in Bangalore. There are a couple of guys called Rahul Singh and Shalini. They worked in UK for 4 to 5 years. They came back and they started with the air ambulance system. Generally, they tend to transfer organs, but I heard that they have done a couple of ECMO transfers as well. It is reasonably costly service even now. These helicopters are very good for us. They are all twin engine helicopters, so that is very, very essential, because within the last year also we heard about helicopter crashes. When they go out as a single engine, it doesn't work. You should have 2 engines in the helicopter. It is unsafe otherwise. Ideally, if you have a bigger mechanism, that is better, but I'm not going into that. I'll come back to the Indian scenario because of the lack of time. This is a purpose-built ECMO ambulance for us. In your hospital, you can build your own transport unit. This is just like take a bed like this and make this a surface. On this surface, one of your biomedical engineers or mechanical welders, they can put surfaces for syringe pumps, ventilator, and also for holding the ECMO console. Just to quote you from the size point of view, Mackie console may be a reasonably small size one to go onto this. You can put any of the consoles on it, but you can prepare something similar to this, and as a transport trolley for you when you are planning for mobile ECMO. Okay, so this is a modified version of what you have seen before. This is the patient platform, patient will lie there, and syringe pumps, monitor, ventilator. Next to that is ECMO console. This compact unit will go out. You can place your patient on that and bring it back. This is a local made one. It can be assembled locally. This is a transport incubator, neonatal incubator. You can see the baby over there, and monitor, ventilator, syringe pumps next to the patient, because these are the sickest ones. Again, an oxygenator and pump. This is a Levatronics one attached to transport trolley. This is a transport trolley. This is Levatronics one. Meadows oxygenator attached to a transport trolley. So this is the way probably we can go. Pranay and Venkat, they have been doing this transport in any of the cities in India. But one of the ways I suggest is if you want to go out, you can fly to those places with your equipment, put the patient on ECMO, that reduces the transport time. You take the equipment with you, you can fly. There's absolutely no problem with that. And when you're coming back, you have to decide which way you are coming back, depending on the distance. You cannot bring them back by flight. It has to be one-way air ambulance, or if road transport is permissible, yes, you can do that. Patient is being brought back on mobile ECMO. This is an adult patient on mobile ECMO in the ambulance. So most probably we are looking for this sort of local arrangements, so that indigenously you can manufacture your own units and make sure they are stable. That is very, very important. In our country, our vision is, at least if we can develop centers locally in each and every state, that reduces the distance. That is our immediate vision at this point of time. I'm really pleased to see you guys coming from all corners of India and rest of the other countries as well, so that we start involving as many states as possible for provision of this service. So locally in each city, it should be able to, they should be able to provide it. We all agreed we can do ECMO and we need to do ECMO. There are problems for us, mainly for the road transport. You know how some of the roads are like, even within the cities also. Once upon a time, I was sitting in the back of the ambulance with my father over there. Then I realized how difficult it is to sustain. Normal individuals also cannot tolerate those bumpy roads, leave alone the patients. So some thought is required, some thought process is required into that, how people drive even in ambulances. Traffic conditions, you know much better than I do. Respecting ambulance vehicles, and ego is one of our problems too. So intercity and inter-hospital transport for stabilization of the patient and cannulation in a different hospital and bringing the patient to your hospital within the city is possible. Mobile ECMO versus mobile teams. What Pranay and Venkat are doing is with the mobile teams, but there is a provision for developing mobile ECMO too. Air transport is costly. I have plans for accessing Indian Air Force at some time. This idea was given to me by one of the persons from Armed Forces Medical College, I suppose. What he said is, pilots have to do set number of hours, say 100 hours a month or something like that. So instead of wasting those many number of hours, once they get a reasonable confidence and competence with a co-pilot, they can freely volunteer to provide air ambulance services within the country. So that is one of the proposal, but that has to be accepted at the topmost level. This is the current scenario with both our Spider-Man in the country, and these are the correct ambulances available for us as well. I had a dream, as there are trains available which are faster services in the country, why can't you have train ambulances? There are compartments of the train. When there is an accident happening at a place, there are medical ambulances within the train service. They go there, they put the patient on, they work there. So similarly, if there are compartments available for people to rent out, you can disconnect them for one fast-going train to another super fast train, and the ECMO patients can be carried in train ambulances. I've been talking about it for the past 5 years. I'm pleased to see train ambulances coming and working now. They don't do critical care service, but they are available in the country. You can look for train ambulances in India. It is there on the Google, you can find them. They are available. So just by working together, by being innovative, we can take this transport medicine forward. Transport medicine is very, very important. Otherwise, we tend to lose lots of lives. Cost is very important. Everybody cannot afford air ambulance. Very minimal number of people will be able to afford air ambulances. So innovative ideas are needed, and we all need to work together for making this a reality. Thank you.